Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 479 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. In this video we discuss patient MPC from part 478 of this pharmacotherapy series. Why did MPC receive prophylactic immunosuppressive therapy with cyclosporine and methotrexate? Graft versus host disease is a leading cause of morbidity and mortality after allogeneic hematopoietic cell transplantation. Without immunosuppression, serious acute graft versus host disease would occur in almost every allogeneic hematopoietic cell transplantation recipient. The most common method used to minimize graft versus host disease risk is to administer prophylactic immunosuppressive therapies, and most patients receive multi-drug graft versus host disease prophylaxis. Historically, acute graft versus host disease was prevented with single drug therapy using anti-thymocyte globulin, cyclophosphamide, methotrexate, or cyclosporine. Anti-thymocyte globulin binds nonspecifically to mononuclear cells and depletes hematopoietic progenitor cells in addition to lymphocytes. Consequently, anti-thymocyte globulin is generally avoided as a prophylactic agent due to the risk of graft failure. The risk of graft versus host disease is greatly reduced by two-drug combination immunosuppression. Although the most widely published regimen is short-course methotrexate plus cyclosporine, there is no consensus with regard to the most effective regimen. Several randomized clinical trials have compared tacrolimus and short-course methotrexate with cyclosporine plus short-course methotrexate in patients undergoing allogeneic hematopoietic cell transplantation using human leukocyte antigen-matched siblings and unrelated donors. Recipients of matched sibling grafts treated with tacrolimus had a lower incidence of grade 2 to 4 acute graft versus host disease, but a similar incidence of chronic graft versus host disease. Overall survival was lower in the tacrolimus group as a result of more toxic deaths in patients with advanced stage disease. However, a higher number of advanced stage disease patients in the tacrolimus methotrexate group make the results of this trial somewhat difficult to interpret. Subsequently, the International Blood and Marrow Transplant Registry conducted a matched control study, which suggested that the survival difference between the two arms of tacrolimus plus short-course methotrexate and cyclosporine plus short-course methotrexate was in fact due to the imbalance in the underlying risk factors. In patients receiving human leukocyte antigen-matched or slightly mismatched unrelated grafts, those given tacrolimus had a lower incidence of grade 2 to 4 acute graft versus host disease, a similar incidence of chronic graft versus host disease, and similar disease-free and overall survival rates. Both regimens are currently used in allogeneic hematopoietic cell transplantation after myeloablative preparative regimens. More recently, the use of mycophenolate mofetil has been studied in allogeneic transplants with myeloablative conditioning used in combination with cyclosporine. It appears to have a similar incidence of acute graft versus host disease and 100-day survival as methotrexate, cyclosporine, yet significantly less severe mucositis and more rapid neutrophil engraftment than the methotrexate, cyclosporine arm. Mycophenolate mofetil is now commonly used in clinical practice in combination with cyclosporine or tacrolimus. MPC received acute graft versus host disease prophylaxis with a 2-drug regimen of short-course methotrexate and cyclosporine, the most common regimen for myeloablative allogeneic conditioning regimens. Using 2 drugs with different mechanisms of immunosuppression, one blocking the activation of T cells, such as in the case of cyclosporine, and the other, such as in the case of methotrexate, blocking the division and clonal expansion of activated T cells, is more effective in decreasing the likelihood of graft versus host disease than one of these agents alone. My next question to you reads: what principles are used in dosing medications used for acute graft versus host disease prophylaxis? Although the various combination immunosuppressive regimens vary slightly by drug, dose, and combination, several guidelines are consistent throughout all regimens. First, methotrexate used for prophylaxis of acute graft versus host disease is withheld or given in reduced doses if mucositis is severe or the patient experiences excessive fluid retention. Fluid retention sites act as a depot for methotrexate accumulation, increasing duration of exposure. Methotrexate for graft versus host disease prophylaxis can delay engraftment, increase the incidence and severity of mucositis, and cause liver function test elevations. The methotrexate dose is reduced in the setting of renal or liver impairment. The calcineurin inhibitors, i.e., cyclosporine, tacrolimus, should be initiated before or immediately after donor cell infusion, day -3 to 0, when used for graft versus host disease prophylaxis. This schedule is recommended because of the known mechanism of action of these agents, which entails blocking the proliferation of cytotoxic T cells by inhibiting production of helper T cell-derived interleukin-2, abbreviated as IL-2. Administering cyclosporine before the donor cell infusion allows inhibition of interleukin-2 secretion to occur before a rejection response has been initiated. Cyclosporine is usually administered intravenously until the gastrointestinal toxicity from a myeloablative preparative regimen has resolved, e.g., for 7 to 21 days. This is because gastrointestinal effects of the preparative regimen, e.g., chemotherapy-induced nausea and vomiting, diarrhea, and graft versus host disease affect the oral absorption of microemulsion cyclosporine and may result in inconsistent blood concentrations. Most centers use the microemulsion oral formulation, marketed as Neoral, or other new generic microemulsion formulations that have improved bioavailability. With the microemulsion oral formulation, an IV to oral dosing ratio of 1:2 or 1:3 is appropriate. The most common ratio used when converting tacrolimus from IV to oral is 1:4. Empiric dose adjustments may be required when patients are receiving concomitant medications, e.g., voriconazole, that affect cytochrome CYP3A4 or P-glycoprotein, which are involved in the metabolism and transport of the calcineurin inhibitors. Thus, careful monitoring for drug interactions with the calcineurin inhibitors is warranted. The dose of cyclosporine or tacrolimus is adjusted based on serum drug levels and the serum creatinine concentration. Although the calcineurin inhibitors do not contribute to myelosuppression, common adverse effects to these agents include electrolyte abnormalities, neurotoxicity, hypertension, and/or nephrotoxicity. Tapering schedules for graft versus host disease prophylaxis vary widely among institutions. The general goal is to keep calcineurin inhibitor doses stable until day positive 50 and then slowly taper with the intent of discontinuing all immunosuppressive agents by 6 months after hematopoietic cell transplantation. By this time, immunologic tolerance has developed, and patients no longer require immunosuppressive therapy. This can only be accomplished if the patient is not experiencing graft versus host disease. On day positive 18, a cyclosporine concentration is measured right before the morning dose, that is trough, and is reported as 392 nanograms per milliliter. So my question to you reads: why are cyclosporine concentrations being obtained for MPC? The role of pharmacokinetic monitoring of the calcineurin inhibitors in hematopoietic cell transplantation patients is not well defined, but is commonly performed because of the established pharmacodynamic associations within solid organ transplant recipients. It is standard practice for hematopoietic cell transplantation centers to adjust cyclosporine or tacrolimus doses based on trough blood concentrations. An association between cyclosporine concentrations and acute graft versus host disease was not found in early studies. However, other studies have suggested that cyclosporine trough concentrations for 12-hour dosing of 200 to 400 nanograms per milliliter in adult patients minimize the risk of acute graft versus host disease and the risk of cyclosporine-induced nephrotoxicity. For continuously infused cyclosporine, higher target blood concentrations of 300 to 500 nanograms per milliliter have been required to prevent graft versus host disease in order to provide an equivalent AUC of exposure to intermittent dosing. It is important to note that cyclosporine-induced nephrotoxicity may occur despite low or normal concentrations of cyclosporine and may be a consequence of other drug or disease-related factors known to influence the development of nephrotoxicity. Additionally, recent studies suggest that trough concentrations do not correlate well with exposure to cyclosporine and that a peak level is better correlated to the AUC. 0 to 12. A peak concentration of greater than 800 nanograms per milliliter may be required to prevent graft versus host disease. Despite this, the data are limited and the routine use of peaks for therapeutic drug monitoring is not recommended. Desired tacrolimus trough concentrations are 5 to 15 nanograms per milliliter. Tacrolimus concentrations greater than 20 nanograms per milliliter have been associated with increased risk of toxicity, primarily nephrotoxicity. Adjustments in tacrolimus dosing for increased serum creatinine should be made in a manner similar to that described for cyclosporine. It is reasonable to adjust MPC's doses to maintain cyclosporine trough concentrations between 200 and 400 nanograms per milliliter. as in all patients undergoing allogeneic hematopoietic cell transplantation with a myeloablative preparative regimen. Recommendations for dose adjustments should be based on cyclosporine concentrations and serum creatinine level. No standard dosage adjustment schedule exists, but most centers adopt their own standardized approach. MPC has a normal serum creatinine, and his cyclosporine trough is 392 nanograms per milliliter. Therefore, his cyclosporine dose should be maintained and the trough repeated in a few days. It may be repeated sooner if an interacting drug is added or discontinued, or if there are toxicity concerns. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 480.